Thank you very much again. I want to share my presentation with about prostate brachytherapy. Again, excuse me before, but I want to thank you this opportunity, and I think it's very nice to meet all together from so many countries. So what we want to share now is one of the best choices probably to treat localized prostate cancer, and then mm, let me go. Okay. What I want to show you is that you have experience in about prostate cancer, and I've looked for papers in Saudi Arabia, but that could be from other countries around. And we know that the incidence rate is not very high at the moment, but it's increasing. It's due to the lower aging population, but in this last decade has increased from by 48% and steady increase in the last years. So, but the reality is, but when you go to have your biopsies to patients with symptoms, they are diagnosed in advanced stages, metastatic, Gleason, high Gleason, PSA over 20. But when you look, as in this other paper, to patients with prostate issues, but no really very symptomatic, you can find 8% of prostate cancer. That means that the screening programs and active treatment is really needed. In fact, you have prepared these guidelines, and I think I congratulate you that you are working together, urologists and radiation oncologists. And the question is that if you have more incidence of prostate cancer, we will find earlier stages, non-metastatic cases, and younger men. Then the question is, which is the best choice? You can you can choose prostatectomy, laparoscopic or robotic, external radiation with AMRT, SBRT. You can choose HDR brachytherapy with needles, or LDR, low-dose rate brachytherapy with permanent seeds. There are different choices. So the question is, why to choose brachytherapy? Well, the rationale is that you can give a higher dose to the prostate. You are giving lower dose to the rest of the body. Of course, lower rectal toxicity and a better erectile preservation. And at the end, you have better long-term results than with external radiation alone. And again, in some early cases, you avoid density of active surveillance. That can be another choice for early cases. But again, you can see on the right that brachytherapy delivers a much higher dose to the target compared with IMRT or SBRT, because we are giving 150% to 100% dose inside the prostate and protecting organs at risk. And again, the question is, well, and why to choose LDR brachytherapy seeds? Well, because we know that it works with a one-day treatment, not that for HDR, that we need at least 2 treatments in different days. We can do an outpatient implant in the same day, it can be possible. We do not need a shielded room for the treatment. And really, with an ultrasound, a laptop, and the seats and system to insert the seats is enough. And maybe the most important is that we have higher control of PSA at 5 years under 0.2. That means that, well, brachytherapy with seeds is giving higher level of control at long term. You can see the comparison between SBRT, HDR, or LDR. So in this situation, PSA level at 4 or 5 years under 0.2, that is considered a biochemical definition of cure, are the best results published at the moment at 10 to 15 years of follow-up. Everything will work in the future probably, but at the moment is what we have. And at the end, indications of brachytherapy, as you can see, is always with brachytherapy for localized prostate cancer, not metastatic cancer. And with this line that we always talk about low, intermediate, high, but we know that we must differentiate the favorable intermediate that can be treated with brachy alone, or unfavorable intermediate or high or very high then when we do a combined treatment, this is the recommended, but brachytherapy is always recommended. Well, permanent radioactive seeds, but which kind of seeds? Well, we can have loose seeds, and we can use stranded seeds. No, there are different ways of doing that. It depends on the experience of every department, because we have different ways of doing the same. But we can use even stranded sources, custom link, that is what I will show now, that in that situation you can adapt the exact position of every seed, and you can keep them in the same position for months. And this is always a good option. Which is the difference at the end? Well, the distribution of seeds after 1 month will be a bit different. At the end, the dose to the whole prostate will not be so different, but we have some advantages of this custom linked or stranded sources. What can we do? We can offer the possibility to give 145 gray to the prostate volume, but you can add extra seeds. What does it mean? That you can give an extra dose to the area where you need, even two extracapsular tumors to T3, because you can add extra seeds. As you can see there, the dose to the prostate volume is the same, but the high dose volume is far higher in the area where you have the tumor, or the high Gleason, or the PRATs 4-5. So what I want to show you is how we work with these custom linked seeds in what we call the 10-step method. I can show down. I have found another method by 10-step. Is not the same, but you can find other ways to explain that. But we want to show you that this is a work of a whole team, and we need, of course, anesthetist at the beginning. We have nurses for the position, catheterization. I will show now step by step. Then we need to insert fixing needles, to take images by the radiation oncologists, the urologists, all together, implant needles, and afterwards to do the dosimetry by the physicist, and of course to prepare the seed strands by the nurse or RTT, and again to insert the seeds by the radiation oncologist and the physicist again. So it's all a team, but it's a system that allows you to use this system in a short time, even in 2 hours. This week we have done 3 patients during a morning. So that, of course, with a trained team. Of course, after the anesthetic procedure, that can be general or spinal, of course, the catheterization is important to fix the catheter in order to have the prostate fixed. With the legs at 90 degrees, it's important to avoid the pubic arc, and with the stabilizer fixed to the table in our system with a stepper, and the horizontal position, again, trying to avoid the pubic arc is really important. So, sorry. Now, so the next step is to insert the fixing needles or harpoons. These anchor needles with the grid allow us to fix the prostate, and then we capture the images with the transrectal ultrasound with the definition of every 5 millimeters. Then you can find the balloon. You can look for every 5 millimeters. You can find what we call the bladder neck, where we do not insert seeds, the base of the prostate, every 5 millimeter slice, the apex, that is not always easy to see, and an extra slice. With that, we move to the next step, that is drawing contours of prostate. You can see on the right the prostate, the urethra. We give a large diameter, 10 millimeters, to avoid and to protect not only the urethra, but a small margin around, and the rectum wall, that is only the anterior wall. you can see down that the image is really clear in the sagittal view, so you can see the balloon on all the shape of the prostate in a way that with external radiation and SCT planning is not possible. So the next step is implantation of peripheral needles in a circular or crown shape. You can see on the left these two first needles on the top, trying to avoid the pubic arc. If not, we change the position of the legs. And as you can see with the needles that are bevel needles, you can direct, sometimes pushing the grid or pulling the grid. So you can direct, you can see in the middle, you can see that we can insert all the needles around the prostate in 1-2 millimeters inside the prostate, and then the other half crown. So in order to cover completely the peripheral area of the prostate. Next step is capture images again. Why? Because we have the needles inserted, so we have small changes, and we need to identify every needle with a number and a letter, and so you can define with your physicist that you know exactly where you are. Again, as you can see, we can adapt perfectly the anatomy in a way that with SCT planning is not possible. And again, you can readapt the shape, the real shape of the prostate with the needles inside. You can see on the right the catheter, the bladder catheter that was not well drawn, so we can change before starting the implant. All this is the preparation for doing the implant. But the way you can see the balloon, the apex, and the bladder wall and the seminal vesicles and rectum is so accurate that really you can prepare a very good distribution of those. Now is the step for the physicist and the dosimetry. We use a seed planning according to modified peripheral distribution. Every single seed you insert, the computer calculates immediately the dose around with these small circles of lines. And this, in this case, you can see on the right that well, maybe we are not covering completely on the left side of the prostate, so we add an extra seed so we can prepare what we are going to do. We have not inserted yet the seeds, so you can prepare an optimal distribution before starting. We are giving 145% to the prostate, sorry, not percent, grade to the prostate with a margin of 2-3 millimeters. Some people like some recommendations to draw a small volume around the prostate, but what we do is to give this dark blue line around the prostate, so you realize that you are covering completely your CTV, that is the prostate itself, with a margin. And we always keeping a low dose to the rectum and a low dose to the maximum dose to the urethra. In this situation, you can see that maybe some extra needle in the middle of the prostate, central needles, can be added if your physicists consider that dosimetry will be better for the base and for the apex. So this is the goal. We can have this distribution around the blue dark is the dose that is covering the whole prostate. And we have a red line that is to avoid the urethra. And in this case, you can see that we are giving even 200% doses in some parts of the prostate. That is not possible with any other kind of external radiation at such amount of dose. And on the right, we can find the B100, the D90. These are very high doses over the prescribed dose. Maybe this is one of the reasons of the good results of this, the SIDS technique. And again, keeping the rectum and urethra in low doses. Next step is to prepare the strands, and then the nurse and technician are mandatory. You can see with the yellow arrows, the separators, the plastic separators, and that then you add the you add in green the seeds that are prepared to avoid radiation to the stuff. So then you prepare all that, and the last step is to insert the seeds with the real-time ultrasound. On the left, you can find that you are inserting, and you can see at the same time in the ultrasound and the computer. So you can look at the tip of the needle. As you can see, the needle is, I've told you, is a bevel needle. So you can perfectly see the top of the needle. And when you arrive to the exact position of the needle as has been prepared in the computer, you can push the strand inside the needle, and you can see how the needle, how the seed is exactly in the exact position. You take out the needle and the strand remains at place. So every change in the position is recalculated at the moment. You can decide if you need to do some change. At the end, the next day or 1 month later, now we prefer to do the next day because we can see the urethra and we can see the distribution, the real distribution in acity. That, as you can see, prostate is not really easy to define, but we in the OR we have seen that we are covering perfectly the prostate again. So the distribution is a high quality dosimetry that is maintained over time with these disease. And which is the result of that? Well, the results are really very good. You know that in early cases and low risk, like on the left, you can see the experience of the Princess Margaret Hospital. Why is so good the result at long term? Well, because the dosimetry is really very good. On the right, you can see the difference with the experience of Leeds in the United Kingdom. That well, the difference is clear. If you have very good dosimetry, over 140%, results are always good, even in intermediate and high risk, compared with cases with not so good dosimetry. Even in this study of 3,000 cases with high doses, intermediate doses or low doses, for low risk, intermediate, and high risk, you can see that whenever you have very high doses, you can achieve very, very good long-term results, even in high-risk cases with monotherapy. So I think that you must keep this in mind, that dosimetry is really important. In some cases, in intermediate or high risk, we have, maybe you all know, this randomized study, the Ascender, comparing intermediate and high risk with a standard radiation therapy in 78 gray against 46 gray to the pelvis plus seed boost. And the difference you can see for the whole number of patients for intermediate or for high risk have a very high difference. In fact, the probability of biochemical failure at 6 years was twice when using external radiation, the failure, and the control was 25 better with the combination that only with external radiation alone. So I think that this is really clear. Always, there are a lot of papers on that, only to show in a quick way, in a quick view, that even for high risk, this is a very nice study in Seattle, with high risk with Gleason 810, but with PSA not very high, so they are selected high risk, but in this case with very good dosimetry, the 90-120%, so very good implants, we can achieve 90% with a combination of combined treatment, even in high risk. So the conclusion of that is that when you have good distribution of radiation, you can achieve very good goals. And again, if we talk about intermediate risk, that usually we can use external radiation or we can use also seeds, you can see in the upper part, the profit, the CHIP, these studies that are well known, comparing hypofractionation with a standard standard radiation therapy, and you know that it's the same nowadays. We are always using hypofractionated schemes for external radiation, but when we compare with LDR brachytherapy, only LDR brachytherapy or a combined treatment in the standard, you can see this plateau with LDR. You can see these lines that cannot be achieved with external radiation. That means that we are having long-term results. So to trying to show why LDR brachytherapy is so useful for prostate cancer. We can choose what we have, but brachytherapy and seeds are really very good because these are slow-growing tumors with a low alpha beta, So that means that LDR in 6 months delivers twice as much dose as external radiation. We are giving 145 to the peripheral area. You know that in the center of the prostate, we are giving very high dose. The poorly definition of CT for external radiation is changing by this excellent definition with ultrasound. Organs at risk are very close. The urethra is inside the CTV, so its isodoses are precisely adjusted to urethra and rectal wall in a way that cannot be achieved with external radiation. The boost on GTV is required, and it's very easy to give a boost with seeds because we can give doses over 250% to these areas that are at high risk. Of course, we have prostate movements between fractions for external radiation, but with seeds, we do not need a PTV. The total volume of radiation is lower, and the high technology needed for an accurate dosimetry for external radiation can be changed with this teamwork, of course, but with a short learning curve because it really is easy to do. So, in conclusion, we have an increased incidence at early stages in younger men. So erectile function is really a very important decision to show what we can do. Prostatectomy, external radiation, everything is useful. You can use what you have, but when you use brachytherapy, you can give higher doses to the target, always compared with any kind of external radiation, even SBRT. It's always recommendation brachytherapy because it's always giving better results on long term. Low dose rate brachytherapy led to a lower nadir of PSA with longer continued decay compared with other techniques at the moment. With custom linked stranded seeds, we can treat even extracapsular tumors, and the real-time planning with custom linked seeds in 10-step implants achieves really very optimal dosimetry in almost every case. Long-term results are excellent with good dosimetry over 145, 45, even 40. So, and we can achieve that. And I will show in the next talk our results in these cases. And the combined external beam plus boost with LDR achieves a plateau of PSA with control at long-term in intermediate and even in high risk. So I consider these are good reasons to choose this option. Thank you very much.